Common mental health issues, classifications in the DSM-5, general and specific personality disorders. So remember, all of the technical information in this PowerPoint comes from the Diagnostic and Statistical Manual of Mental Disorders as published by the American Psychiatric Association. Something to keep in mind as I go through these PowerPoints is that the DSM is a categorical way to look at mental health issues. It is included here so that if and when a client or patient comes into your office or clinic or practice and states that they have been diagnosed with a disorder, you have at least a rudimentary understanding of what it is that they are talking about. I'm on the side of depathologizing and destigmatizing mental health issues, and I encourage all of you to seek to find out what may be driving the behavior that has been categorized or compartmentalized into a set of criteria. Expressed behavior that fits a diagnosis can be looked at as an adaptation to experiences or life events that felt overwhelming, chaotic, and sometimes even life-threatening. Learn about these definitions, diagnosis, and criteria. It's important, but always keep in mind that you are looking at and you are working with a person that may have had to learn ways to cope in less than ideal circumstances. And of course, I ask you to, above all, stay curious about the person, not the condition. Personality disorders, described as a pattern of inner experience and behavior that deviates markedly from the expectations of the individual's culture. It is pervasive and inflexible. Generally, there is an onset in adolescence or early adulthood, tends to be stable over time, and leads to distress or impairment. It is important to note that integration, clinical utility, and the relationship with personality disorder diagnostic criteria has in various aspects of personality dysfunction are under active investigation. So, general personality disorder, there is an enduring pattern of inner experience and behavior that deviates markedly from the expectations of the individual's culture. So this pattern is manifested in two or more of the following areas: cognition, affectivity, interpersonal functioning, and impulse control. The development and course. The features of a personality disorder usually become recognizable during adolescence or early adulthood. There's an enduring pattern of thinking, behaving, and feeling that is relatively stable over time. Some personality disorders tend to become less evident or to remit with age, whereas this appears to be less true for other types. It is important to know that traits of a personality disorder that appear in childhood often do not persist unchanged into adulthood. Diagnosis of personality disorder is in an individual younger than 18 years of age must have features persisting for at least a year. The one exception to this is antisocial personality disorder, which cannot and is not diagnosed in an individual younger than 18 years of age. When we talk about culture and gender, as individuals' ethnic, cultural, and social background must be taken into consideration and should not be confused with problems associated with acculturation following immigration or with the expression of habits, customs, or religious and political values professed by the individual's culture of origin. Certain personality disorders are more commonly diagnosed in one gender over another. It is important for clinicians to be cautious of overdiagnosing or underdiagnosing certain personality disorders in one gender because of social stereotypes about typical gender roles and behaviors. I'm going to be going through the different clusters on how these diagnoses of personality disorder show up in the DSM-5. We'll start with cluster A. Cluster A. So this is characterized by odd, eccentric thinking or behavior. Paranoid personality disorder. Some essential features of this disorder is a pattern of pervasive distrust and suspiciousness of others whose motives are interpreted often as malevolent. This pattern tends to begin in early adulthood and is present in a variety of contexts. Individuals with this disorder assume that others are attempting to exploit, harm, or deceive them, even if no evidence exists to support this accusation. They are often reluctant to confide in or become close to others because they fear that the information they share will be used against them. They may refuse to answer personal questions. They assume hidden meanings in benign remarks or events and may misinterpret an honest mistake as a deliberate attempt to cause harm. Compliments are often misinterpreted, and they may view an offer of help as criticism that they're not doing well enough on their own. Individuals with this disorder may be overly jealous and suspicious that their spouse or sexual partner is unfaithful without any justification. Some clinical features of paranoid personality disorder may first appear in childhood and adolescence. Oftentimes this shows up as solitariness, poor peer relationships, social anxiety, underachievement in school, hypersensitivity, peculiar thoughts and language, or idiosyncratic fantasies. There is some evidence for it. It has increased prevalence in paranoid personality disorder in relatives with schizophrenia, or more specific, familial relationships, people that have delusional disorder with persecutory typology. Culturally, behaviors that may be influenced by social culture context, cultural context for specific life circumstances may be mislabeled as paranoid. Members of minority groups, immigrants, political or economic refugees, or individuals of differing ethnic backgrounds may display guarded or defensive behaviors because of unfamiliarity. Careful assessment and considerations must be given. In schizoid personality disorder, an essential feature is a pervasive pattern of detachment from social relationships and restricted range of expression of emotions in interpersonal settings. This pattern tends to begin in early adulthood. So clinical features. Persons with this personality disorder tend to display the following patterns. They lack a desire for close relationships, including those with their family members. Nearly always choose solitary activities, little, if any, interest in having sexual experiences with another person. Pleasure in few, if any, activities, lack of close friends, or confidence other than first-degree relatives. Appears indifferent to the praise or criticism of others. There's displays of emotional coldness, detachment, or flattened affectivity. Cultural considerations. So something to take into consideration is that a variety of cultural backgrounds sometimes exhibit defensive behaviors in interpersonal styles that may be erroneously labeled as schizoid. An example would be a person moving from one area to another may react with emotional freezing that can last for several months and may manifest as solitary activities. Constricted affect, another deficit, some kinds of deficit in communications. Immigrants from other countries are sometimes mistakenly perceived as cold, hostile, or indifferent. Again, careful assessment and a thorough history must be taken. Schizotypal personality disorder. With this, there is a pervasive pattern of social and interpersonal deficits marked by acute discomfort with and reduced capacity for close relationships, as well as cognitive or perceptual distortions. The patterns tend to begin again in early adulthood and present in a variety of contexts. Clinical features, there may be odd behavior or magical thinking that influences behavior. It is inconsistent with subcultural norms. Unusual perceptual experiences, including bodily illusions, odd thinking in speech, suspicious or paranoid ideations, inappropriate or constricted affect, behavior, appearance that is odd, eccentric, or peculiar, lack of close friends or confidants, other than first-degree relatives. Excessive social anxiety that does not diminish with familiarity and tends to be associated with paranoid fears rather than negative judgments about the self. With development in course, this personality disorder tends to be relatively stable over time, with only a small proportion of individuals going on to develop the more serious condition of schizophrenia or another psychotic disorder, which will be discussed later. Children displaying symptoms such as odd or eccentric behavior may attract teasing and bullying by other children. So that can come along with its own set of issues going along with that. Culture, cognitive and perceptual disorders may be evaluated in the context of individual cultures. So there may be religious beliefs and rituals that can appear to be schizotypal to the uninformed outsider. For example, speaking in tongues, talking about things like life beyond death. Chauvinism is another one. People that display a sixth sense, the evil eye, magical beliefs that can be related to health and illness. When we move on to cluster B, these are characterized by dramatic, overly emotional, or unpredictable thinking or behaving. Starting out with antisocial personality disorder, there is a pervasive pattern of disregard for and violation of the rights of others that begins oftentimes in childhood or early adolescence. It tends to continue into adulthood. This has often been referred to as psychopathy. Or dissocial personality disorder. Sociopathy is another term that people have oftentimes used with this. Clinical features. So there tends to be failure to conform to social norms with respect to lawful behavior. Deceitfulness, impulsivity, or failure to plan ahead, irritability and aggressiveness, reckless disregard for safety of others and self, and consistent irresponsibility and a lack of remorse. Development and course. Antisocial personality disorder has a chronic course, but may become less evident or remit as the individual grows older, particularly by the fourth decade of life. Clinically, antisocial personality disorder is not to be diagnosed before a person becomes 18. Risk and prognostic factors. Antisocial personality disorder is more common among individuals with first-degree biological relatives with this disorder. There also tends to be a risk for somatic symptom disorder and substance use disorder in biological relatives of individuals with this disorder. This may bring up thoughts about adverse childhood experiences, which will be discussed in further detail in another section. Culture and gender. According to the DSM, antisocial personality disorder appears to be associated with low socioeconomic status and urban settings. Concerns have been raised that this diagnosis may at times be misapplied to individuals in settings in which seemingly antisocial personality disorder behavior may be part of the protective survival strategy. So this must be taken into consideration by a clinician before a diagnosis is made. Male identifying people are more commonly diagnosed than female identifying. However, there is concern that there may be an underdiagnosis in female identifying, particularly because of the emphasis on aggressive items in the definition of conduct disorders. Borderline personality disorder has the essential feature of a pervasive pattern of instability in interpersonal relationships, self-esteem issues, and affect. There is marked impulsivity that begins by early adulthood and is present in a variety of contexts. With some clinical features, individuals display behaviors that appear chaotic in order to avoid real or imagined abandonment. There can be displays of patterns of unstable and intense interpersonal relationship characterized by alternating between extremes of idealization and devaluation. There's marked and persistently unstable self-image or a sense of self, impulsivity in areas that are potentially self-damaging, for example, excessive spending, sex, substance abuse, reckless driving, and binge eating. There is often recurrent suicidal behavior, gestures or threats, or self-mutilating behavior. Affect instability is due to a marked reactivity of mood. There are repeated and reported chronic feelings of emptiness, inappropriate intense anger or difficulty controlling anger, transient stress-related paranoid ideation, or severe dissociative symptoms. So the development and course. There is considerable variation in the course of borderline personality disorder, with common patterns being chronic instability in early adulthood, with episodes of serious affect, impulse control issues, and high levels of overuse of health and mental health resources. The impairment of this disorder and risk of suicide are greatest in young adult years, gradually waning with advancing age. culture and gender. This disorder has been identified in multiple settings around the world. Adolescents and young adults with identity problems may display behaviors that give the impression of borderline personality disorder. However, this borderline personality disorder is diagnosed predominantly in female identifying people. However, that does not mean that male identifying persons do not display related behaviors. Something to consider is the prevalence of a history of abuse and neglect. Consider the behavior patterns, again, created during developmental stages of life. If you have a withdrawn, abusive, or neglectful caregiver that displays inconsistent patterns of attachment, what might a child need to do to maintain connection and ultimately to remain and keep levels of feelings of safety? Histrionic personality disorder. So this disorder shows a pervasiveness and excessive emotionality and attention-seeking behavior with patterns beginning in early adulthood and present in a variety of contexts. Individuals with this disorder are uncomfortable or feel unappreciated when they are not the center of attention. They often live in an overly dramatic fashion, attempting to draw attention to themselves, and may initially be charmed by new acquaintances because of their enthusiasm, apparent openness, and/or flirtatiousness. Clinical features, symptomatic features of this disorder are related to discomfort in situations in which he or she is not the center of attention, interactions with others being inappropriate, often in a sexually seductive or provocative manner, rapidly shifting and shallow expressions of emotion, consistent use of physical appearance to draw attention to oneself, a style of speech that may appear to be excessively impressionistic and lack in detail. There can be self-dramatization, theatricality, and exaggerated expressions of emotions. Individuals with this personality type are often overly suggestible, easily influenced by others or circumstances, and consider relationships to be more intimate than they actually are. With narcissistic personality disorder, this shows a pervasive pattern of grandiosity, need for admiration, and lack of empathy that begins by early adulthood and is present in a variety of contexts. With clinical features, individuals with this disorder have a grandiose sense of self-importance. They routinely overestimate their abilities and inflate their accomplishments, often appearing boastful and pretentious. They often assume that others attribute the same value to their efforts and may be surprised when the praise they expected and feel they deserve is not given. Those with this personality disorder may ruminate about the long overdue admiration and privilege and compare themselves favorably with famous or privileged people. They believe they are superior, special, or unique and expect others to recognize them as such. They often feel they can only be understood by and should only associate with other people who are special or have high status and may attribute unique, perfect, or gifted qualities to those with whom they associate. People with narcissistic personality disorder often believe that their needs are special and beyond that of ordinary people. They often demand admiration and may become dismissive of people who fail to live up to their expectations that they hold. They are often preoccupied with how well they are doing and how favorably they are regarded by others. The demand for admiration and recognition may at times be consistent depending on the level of stress. They often display a sense of entitlement with the expectation of favorable treatment. Individuals with this personality disorder generally lack empathy and have difficulty recognizing the desires, subjective experiences, and feelings of others. They often display contempt and impatience with others who talk about their own problems and concerns. As far as development and course, narcissistic traits may be common in adolescence and do not necessarily indicate that the individual will go on to have narcissistic personality disorder. One thing to take into consideration is the fact that all children begin with narcissistic features. It's just a part of our natural development to see ourselves as the center of the universe. When people fail to develop empathy, compassion, and the ability to see the interconnectedness of all beings, that is part of the disorder. This personality disorder is on a continuum of mild, which is common and generally not an issue. However, the closer the traits get to malignant, the more destructive and dangerous the person is. Some associated features Our feelings of vulnerability and self-esteem make individuals with this disorder very sensitive to injury from criticism. They may not have outward signs of this internal injury. However, they oftentimes feel humiliated, degraded, hollow, and empty. They may react with disdain, rage, or defiant counterattacks. Sustained feelings of shame or humiliation and the attendant self-criticism may be associated with social withdrawal, depressed mood, and persistent depressive disorder, or even major depressive disorder. People with this trait often end up in therapy because they are forced by a spouse or human resources at their job and are only able to see how they are the ones that are being wronged. Cluster C is characterized by anxious, fearful thinking or behavior. Start with avoidant personality disorder. This is the diagnostic features include pervasive pattern of social inhibition, feelings of inadequacy, and hypersensitivity to any kind of negative evaluation that begins by early adulthood and is present again in a variety of contexts. So clinical features. This disorder often begins in infancy or childhood with shyness, isolation, and fear of strangers and new situations. So this is a pattern that goes beyond developmental stages. These patterns of behavior tend not to diminish with age and may even become increasingly shy and avoidant during adolescence and early adulthood. There may be a progression to more severe disorders such as agoraphobia. With dependent personality disorder, the essential feature is pervasive and excessive need to be taken care of that leads to submissiveness and clingy behavior and fears of separation. Clinical features here. So the patterns begin by early adulthood and are present in a variety of contexts. Persons with this disorder may exhibit submissive behaviors that are designed to elicit caregiving and arise from the self-perception of being unable or inadequate to function without the help of others. They often have great difficulty making everyday decisions without an excessive amount of advice and reassurance from others. They tend to be passive and allow other people to take initiative and assume responsibility for most major areas of their life. Adults with this disorder typically depend on parents or spouses to decide everything from occupations to friends to living situations. Adolescents may display behaviors in which they seek advice about what clothes to wear, with whom they should associate, and how they should spend their free time, what school or college they should attend. And these responsibilities go well beyond age-appropriate situations or appropriate requests for assistance from others. People with this personality type often have difficulty expressing disagreement with others. They often believe that they are unable to function in the absence of a close relationship, which motivates them to quickly become attached indiscriminately to another individual at the end of any other significant relationship. Culturally, the degree to which this type of behaviors are considered appropriate vary substantially across age and sociocultural groups. Factors need to be considered in evaluating the diagnostic threshold for each criteria, including dependent behaviors that are considered characteristic of the disorder only when it is clearly in excess of the individual's cultural norms or reflects unrealistic concerns. An emphasis on passivity, politeness, and deferential treatment is characteristic of some societies and may be misinterpreted or misdiagnosed traits of dependency personality disorder. Again, it's very important to have a cultural understanding of your clients. With obsessive compulsive personality disorder, as was discussed earlier, this personality disorder is defined as a preoccupation with orderliness, perfectionism, and mental and interpersonal control at the expense of flexibility, openness, and efficiency. Clinical features include attempts to maintain a sense of control through painstaking attention to rules, trivial details, procedures, lists, schedules, or form to the extent that the major point of the activity is lost. They are often excessively careful and prone to repetition, paying extraordinary attention to detail and repeatedly checking for possible mistakes. Time is often poorly allocated, and the most important tasks are often left to the last minute. There are high standards that are self-imposed related to performance and perfectionism that cause dysfunction and distress in these individuals. Deadlines are often missed in aspects of the individual's life that are not the current focus of the activity and may fall into disarray. Individuals with this disorder may be excessively conscientious, scrupulous, and inflexible about matters of morality, ethics, or values. They may display rigid moral principles and very strict standards of performance. They are often mercilessly self-critical about their own mistakes. Some associated features: individuals with this personality disorder have difficulty deciding which tasks may take priority, to the point where things never get started. They may become overly upset or angry in situations in which they are not able to take control or maintain control of their physical and interpersonal environment. Although the anger is typically not expressed directly, anger may be expressed with righteous indignation over a seemingly minor matter. They may be especially attentive to their status in dominant submission relationships. They may display excessive deference to authority. They may respect and show excessive resistance to an authority that they do not respect.